So hello everyone and welcome to the webinar on Bridging Perspectives in Home Care. My name's Barbara Hanratty. I'm Professor of Primary Care and Public Health at Newcastle University, and I'm standing in today for Professor Debbie Price. There are still a few people coming in, so but I think we'll start as it's 12:02. Today we're going to hear two short presentations based on work that we did within the NIHR Older People and Frailty Policy Research Unit. This is a collaboration between Manchester, Newcastle universities and the London School of Economics from 2019 to 2023, and we're now funded as the Healthy Ageing Policy Research Unit until 2028. So today, both presentations are concerned with different aspects of home care, paid for social care in the home. And because of the remit of our units, you'll notice that there is a focus on older people. First presentation considers the meaning of quality in home care for older people. And the second explores ideas around the data that it may be useful to have if a minimum data set was defined for home care. So throughout the webinar, we'll post useful links or reports or anything relevant within the chat. And after each presentation, we'll have a pause and some time for questions. It would be very helpful if you have a question, if you could pose it in the Q&A slot. So if you look at the top of your screen, there's a Q&A logo. If you can access that, please type your question in and we'll curate them and answer as many as we can within the time available after each presentation. In the past, we found that some people, because of firewalls and different browsers, are unable to access that function. If that's the case for you, please use the chat and we'll try to keep an eye on both of those locations. At the end of the presentation, if we've got unanswered questions, which we expect we will actually collate a written response and send that out by email when we send out the link to the recording. We do aim to keep fairly strictly to time, and that's going to be my role today, and we definitely will finish by 1 o'clock at the latest. So I think I'm going to hand over now to our first speaker, who's Alex Hall from the University of Manchester.
Thank you very much, Barbara. Good afternoon, everyone. Yeah, so my name's Alex Hall. I'm a lecturer at the University of Manchester in the School of Health Sciences. And I'm going to present today on an evidence review that we have recently finished, which is about the meaning of quality of home care. So this project, we were interested in what do people think of when they think of quality home care for older people. So it's quite a broad conceptual piece of work. We wanted to explore this question by reviewing literature, published literature on home care. So the aims of the project were to summarise the meanings of quality of home care for older people that are held by different people, by key stakeholder groups. We wanted to look at whether what similarities and differences might be between different people's understandings of quality in this area, and to identify what measures of quality we used within the literature that we reviewed about home care for older people. And how they might be used. So a little bit of background, first of all. I'm sure some of you will be familiar with home care, but some of you may not be. So in England, there are just over 800,000 people receiving home care from around 12,000 providers. So it's a large and quite fragmented market of home care providers and services. And over the last 10 years or more, there have really been some enduring challenges around recruitment and retention within the home care sector. So in 2012, the Care Quality Commission undertook a major themed inspection programme that highlighted a range of challenges for the sector relating to staffing levels, skills, knowledge, involvement of people and families in care plans, and the sort of support provided to staff by management. And the Care Act in 2014 then introduced further obligations on local authorities to assess and meet people's care needs where eligible, but of course in the context of budget pressures of the time. And over the sort of 10 years since then, there's been other work that has shown that these kind of pressures and challenges have really endured. So the latest King's Fund Social Care 360 highlights the unattractiveness of the sector, and other work has shown the sort of high prevalence of 0 hours contracts, low pay, etc. So, as I'm sure many of you know, the role of the CQC is to inspect, rate and regulate services to assess the quality and safety of care. And in 2015, NICE produced some guidelines for standards in home care, and the Health and Social Care Act also sets out regulations, including a number of fundamental standards below which care must not fall. But what's really key recently is that last year the CQC now has a new single assessment framework, which is to assess all providers and local authorities' delivery of Care Act duties. And I'll come back to this towards the end of the presentation. Just to highlight, though, that again, I'm sure you're aware the CQC sets out minimum standards for a broad range of aspects of care that you can see on the left there about how people are treated and supported. And their inspections focus on questions around 5 key areas for social care services. Now, the new single assessment framework has 50 different domains that are expressed as we statements or I statements. And again, we'll touch on these at the end of the presentation. But you can see at the bottom there that the vast majority of home care services are rated as good by the CQC. Only very, very few actually reach that top rating of outstanding. So there are many different views, different groups of people who may have different views on what is meant by good quality care. So, for example, is it about supporting people to stay connected to friends and family? Is it about supporting people to make choices and enjoy what they like doing? Is it about focus on optimum health? Is it about value money, responsive, timely service provision? So to what extent might these things be compatible or incompatible with one another? And ultimately, what does this mean for a regulatory framework like that of the CQC? So to do our review, we adopted an approach called a scoping review, which is a form of systematically searching and reviewing evidence. And we were looking at academic evidence from high-income countries. And within the UK, we also considered what major relevant organisations working in the space might have to say about quality of care. And we were looking at evidence from 2016. So we considered just over 5,000 articles and included just under 100 in our review. So this table just gives a rough idea of the geographical spread of the work. We included work from 16 countries, just to draw attention to the fact that in addition to the UK, we found quite a lot of work from the Nordic countries, which isn't that surprising given their care systems and history of work in this area. So the majority of articles focused on home care for the general older population, but about a quarter of them focused specifically on home care for people with dementia. Many articles focused on the views of multiple stakeholder groups or groups of people. So the views of older people were captured in 46 of the articles we included. The views of family members were captured in 19 of the articles included, and so on there that you can see. But as I said, often articles captured the views of multiple groups of people. So in our analysis, we initially built up a list of sub-dimensions about quality that we were seeing in the articles, and then we grouped these into 4 higher level dimensions. So I'm going to summarise each of the 4 higher dimensions briefly. And there's also some overlap between the dimensions. So, for example, you can see on the left here that there was information about maintaining dignity, which was part of a broader dimension about relationships between people, but it's also part of a dimension about bespoke or personalised care. A lot of aspects here on this slide relate to a third dimension about organisational and structural aspects of care. And again, some of these overlap with the ability to develop relationships and provide bespoke personalised care that's shown on the previous slide. And the final dimension is about quality as being measurable. So I'll go through each of these 4 main dimensions now. So the first dimension was about emphasising how quality of care is about relationships between people. So this was present in 43 of the articles we reviewed, again in most of the countries. And it's really about fundamentally that good quality care is about the development and maintenance of relationships between care workers, older people, and the families. And this is usually seen to involve continuity of care, particularly the case for people with dementia, where this is felt to be really important. Some studies highlighted challenges for care staff in this dimension in terms of negotiating boundaries. There were quite a few articles that talked about staff sort of becoming part of the family, but also cautioning about not becoming too close. And it's quite difficult to see that how staff navigate these boundaries, and there can be some challenges here. This figure here just illustrates the broad similarities and differences according to major groups of people, and we can see that older people and family members both appear to have very similar views about what quality looks like in terms of relationships and continuity. There may be some slightly subtle differences between those views and what care workers and managers think, but nonetheless the take-home message here is that there is broad consensus about quality in terms of relationships and continuity of care. So the second dimension is about what we're calling bespoke care. So this is again, this was present in a high proportion of the articles we reviewed, and it's really about person-centered care, but it includes reference to compassionate, empathetic care, facilitates choice and control, and maintains dignity and independence. And perhaps unsurprisingly, there were largely uniform views here about this aspect as being really important. But there were some divergent views. So some information suggesting that not everybody would want to be involved in decisions about the care. Not everybody may voice their needs or desires, possibly out of politeness or awareness of organisational and resource constraints, and some information about possibly home care should meet people's needs, but may not be able to give people everything that they want, although the distinction here is unclear. Again, you don't have to read everything on this slide, but I think it clearly shows that across the main groups of people, once again, there are very similar views on this aspect of quality, and the slightly divergent views I mentioned were highlighted only in one or two studies. The third dimension is about the organisational structural aspects of care, and this was the largest and most complex dimension, with clear overlaps between the other two dimensions. So it's really emphasising that good quality care comes from having sufficient numbers of well-trained, suitably skilled staff, appropriately remunerated, who have the flexibility and time to deliver care. It's also about how easily care recipients and families can find information about services and navigate services and systems. And it's about integration of home care services within health and care systems more broadly. Once again, great.
Alex, I'm sorry Alex, sorry to interrupt you, but so we're seeing a message that your computer is about to restart.
Sorry.
So I just wouldn't like that to happen to you. Thank you.
Thank you, Barbara. Sorry, I wasn't sure if you could see that, but I think I'll have enough time before it boots me out. So this figure shows a lot of overlap between the main groups of people. So perhaps unsurprisingly, older people and families were thinking more about cost of care in terms of care being appropriately priced, whereas care workers and managers may have been thinking about the financial side in terms of paying conditions. But if you excuse the pun, they're kind of two sides of the same coin, really. But again, the take message here is that there is a lot of overlap and similarity of view between different groups of people. So the final dimension is about quality being a measurable construct within this literature. So this was primarily the view articulated by managers, expert commentators, researchers, rather than older people or family members. We identified 13 instruments measuring quality, which all focused on fairly similar aspects of care. But it was interesting that some studies reported uncertainty among managers and providers about exactly what data to collect. So whilst measuring quality is seen as being important, it's not necessarily entirely clear about exactly how it should be measured. So just to bring this all together, I think we have seen very clear, consistent, widely held views about what quality of home care for older people means. It's about good relationships between staff, family and recipients, often linked to continuity of care. It's bespoke with elements of person-centered care. It requires appropriate numbers and diversity of well-trained staff whose pay and working conditions recognise the importance and complexities of the roles, and that have sufficient time and flexibility to deliver care that people need and people want. It's also about connection of the workforce to wider infrastructure within health and care systems. It's about effective communication between organisations, and it should be measurable, but there's some uncertainty about exactly what or how this should be done. It was less clear from the literature we reviewed how to achieve care that fully aligns with what people see as high quality. What models of care can deliver high quality care within the context of organisational and structural challenges. We know less about whether people feel they're actually getting quality care. We don't know that much about how people say what they want or complain about what they don't like, and what happens if they complain. And remember, I said at the start that only 4% of home care is rated outstanding by the CQC. So how far is it possible for providers to really get to this rating, or what are the motivations for them to do so? And just to close on what we think this means for the CQC's framework. So many of the 50 statements are reflected in the findings of our review, but there are some gaps here about relationships, continuity of care, diversity of the workforce, pay and conditions, some of these organisational aspects, and also the weighting of the statements. So we end our report by raising the question of how far this assessment framework is really asking the questions that matter to people. So this wasn't the main focus of our project, so we can't offer a clear answer on this, but we think it's worth posing the questions, and I will just leave you with that thought. So I will end there. Thank you very much.
Thanks, Alex. So if anyone would like to ask a question, please do type it into the chat. I'll just give you a minute. If there are no immediate questions, we can move on. But if you, great, thank you. First question from James, who's asking if you could say some more about the 13 instruments used to measure the quality, which is dimension 4. Did you perceive them to be useful, and what were they?
Yeah, thanks. That's a really good question. I am just going to remind myself exactly of what they were. So first of all, I think that it's important to say that this, because our review was focusing on work published since 2016, it wasn't a review specifically of instruments of quality measurement. So we're aware that there are quite a lot of work to develop quality measures predates the work that we were including. So it really, we're talking about where quality was measured within the particular literature. So there are a range of measures that we found, some of which will be commonly known to people. So work by the INTERI group is one of the measures that are used. As to whether they are useful for quality, again, that wasn't a direct focus here of our study. We were really just trying to describe the kind of measures that were used in this literature. So we would need to investigate that further. So I'm sorry, I can't really offer anything more comprehensive on that, but we were just trying to sort of chart the measures that have been used in the literature.
Thanks, Alex. Question from Monica about, did you find equal perspectives represented across the stakeholder groups?
In terms of the sort of proportion of studies that addressed the different stakeholders, I think we had more views of older people and family members. So I'm just going to have a quick look at my slide from that. So yeah, around half of the articles focused on the views of older people. So they were that I think that I would say they were the main group whose views were represented. But then, so smaller numbers of papers had articulated the views of family members or care workers or managers. But it was fairly even across those groups. So yeah, slightly more in favour of older people, but the other groups were also quite well represented.
There's two questions that I think I'll put together. From Becky, who's asking, how did you approach the variations between culture, views on formal care and different social care systems when considering the generalisability between countries? And Mike asking specifically what you searched for in the articles in the scoping review.
Yeah, so it's one of the challenges we have when doing this kind of review is exactly that in terms of the international comparison, because we recognise that I think in the UK we kind of have a specific understanding of social care more broadly and home care that's perhaps less it's perhaps not replicated in other countries, or it looks slightly different. So we again, because it was a scoping review, which is a more of a sort of higher level approach, we were really trying to look at the main dimensions of quality, and I think the fact that we found such unanimous kind of dimensions or sort of concepts being talked about says that, you know, if we were to look further at the subtle differences between systems, I think we would still see the same kind of messages there. You know, we reviewed over 5,000 articles and we've included just under 100, so I think we're pretty confident in the sort of consistency of the message that we're presenting, really. The second question, sorry, was it about the methods and searching more detail?
Exactly what we were searching for.
Yeah, we were looking for quality, but we took quite a broad approach here, because we wanted, so some of the papers had specifically, the studies had specifically looked at the question of what quality is, but some of the papers were looking at broader questions in which were informed by an understanding of delivering quality care. So, you know, we tried to be as inclusive as possible about different studies that might be capturing aspects of quality, if that makes sense.
There's a couple of questions and comments that go slightly beyond the work, but I don't know if you want to comment on this, Alex. That how do recipients of care measure the care that they may be receiving against expected standards when they will have nothing to compare it against?
Yeah, that's a very difficult question to answer. I'm not really sure I can actually answer that at the moment. I don't know, Barbara, you might be able to help me out here with this, but
it's such an interesting comment and
yeah, it
an
is.
important point. But it does go beyond the work that Alex is presenting today. I think there's also another question in the chat about how far we would trust CQC home care ratings, given that the inspector doesn't accompany care workers, and they speak to care recipients by phone. Again, that's beyond really the scope of what we were doing here. We weren't evaluating the CQC ratings. This was very much an academic look at conceptualizations of quality of home care within the published literature. So I don't know if you've got any comments on that, Alex, but it's perceived trust in the ratings is again an important issue, but
yeah, nothing further to add, Barbara. Thanks. I think it's important to say, yes, we weren't evaluating the CQC here. We're just offering some comments, possibly based on what we found.
And I think this is probably final question, but again, an important issue. Were the views of people living with dementia captured to the extent you would expect?
Yeah, that's an interesting question. So around a quarter of the papers we included had focused on home care for people with dementia. Off the top of my head, I can't remember how many of those papers had focused on the views of the care recipient themselves compared to the family members or care providers. But I think it gives you some idea of the proportion of work that we found that had focused on home care for dementia. Is that what I would expect? Yes, probably, I suppose, and I suspect we may see more work around this area increasing. Yeah, but I think it's around a quarter of the work that looked at dementia home care specifically.
Okay, and actually one final question. This is from Rosie asking, did you come across any negative outcomes from the shift to personalised or person-centred care, i.e. challenges with rapidly declining conditions, staff holding various perspectives of flexible care plans, etc.? I think that's slightly out with the scope of the review, though you may have some comment on it in terms of your reading, Alex.
Negative. I mean, we weren't specifically looking at change over time, I would say. So, you know, we've included work from the last 7 or 8 years, but we were really just sort of trying to describe at a sort of fairly cross-sectional level, if that makes sense, about views of quality. So we haven't actually looked at change over time, but I think it's a really interesting question.
That's great. Thank you so much, Alex. And if there are any unanswered questions, we will respond when we circulate the link to the recording. I'm going to move on now and introduce Vanessa from Newcastle University, who's going to speak about the content of a minimum data set for home care.
Hi, hello everyone. Thank you, Barbara. So my name is Vanessa Davey. I work as a research fellow at Newcastle University with my time spread currently across the NIHR Older People and Frailty Policy Research Unit and the Applied Research Collaboration for the North East and North Cumbria. So I'm here today to speak to you about our project on exploring what might be the possible content of a minimum data set for home care, which I think follows on nicely from Alex's presentation. So Alex has already given us a really rich description of the context of home care, not just in England, but obviously in other countries. Just to recap and underline a few points, as was explained, home care provides services to around 800,000 people, and that number is approximately twice the number of people who are living in care homes. By comparison to the population of people in care homes, very little is known about the home care population, but what we do know is that people who receive support with daily activities are likely to have at least one, if not multiple, long-term health conditions. That data gap means that there's no straightforward way to get a snapshot of local or national home care population at any given time. And this creates many limitations when it comes to having meaningful intelligence for care planning and provision, and it's seen as a real critical point now, and also, as was previously discussed, around the need to improve quality monitoring. So also given the precarious home care context, which Alex described, the difficulties with recruiting and retaining staff, it seems as though it's perhaps more important than ever that we find ways to improve our understanding of home care. And the final point to mention is that with the drive to digitalisation, with the introduction of digital social care records, what we do now have is an opportunity to do so in a way that we didn't have before. So moving on to the concept of a minimum data set for home care, which I'm going to explain to you now. And just to explain here that the work that I'm presenting now is work that was extended from the Datcha study, which has successfully developed and trialed a minimum data set in care homes. And if you're more interested in that, they have a very full website which you can access via the link there. And we initially started in this field as a small exploratory study to look at the feasibility and acceptability of developing a minimum data set in home care. And from that, we have moved on to look at what might be the potential content of that. But to start with, we need to define what a minimum data set for home care, what we mean by a minimum data set for home care. So primarily, it's a core set of information on individual health, well-being and quality of life that would be routinely collected and collated. And it's important that it has the capacity through the way it's developed to be able to link to other data sources. And moreover, that the minimum data set would have multiple applications, including, for example, quality improvement. This definition, of course, needs to be underpinned by principles. And for our work in home care, what we've done is to draw on principles, draw on and adapt principles that were already developed as part of the Datcha project that had been published in the article linked below. Sorry. Okay, so we believe that it must measure what matters most to people receiving home care. That's obviously not a straightforward principle to establish, given that there are many stakeholders and aspirations for data use. Therefore, we commit to developing a minimum data set which is evidence-based, both in design and content, and co-produced with key stakeholders. And among our aspirations, we believe that data that is collected should help with providing insight into the organisation and design of home care, help us to understand why delivering home care might be particularly challenging in certain circumstances, and help us to understand how home care supports the quality of life for older people and, where relevant, their main carer. Alongside this, there are obviously other crucial requisites to ensure that a minimum data set adds value and supports better outcomes, and those need to be around reducing data burden, duplication, ensuring that home care providers can use the data, and ensuring adequate privacy, as well as linking up, being able to link to other sources of data to get its full potential. So drawing on all those principles for this project, our aim was to explore the potential content for a minimum data set for home care that is feasible and acceptable to relevant stakeholders. So we did this by identifying relevant gaps, items and gaps in the minimum data set for care homes, conducting a scoping review of published evidence to identify potential tools for home care specifically around areas that might be missing from the MDS for care homes that would be relevant to a home care setting. And finally, through stakeholder consultation. So our first task was to look at how well the MDS for care home maps to a home care setting and what would be relevant and what might not be relevant. So all of the items here that are in blue are areas or domains, as it were, of the MDS for care home, which are directly relevant to home care. And then the items which are in turquoise are what stakeholders that we spoke to when we talked about aspirations for MDS data and what might need to be added told us were important. And specifically, one of the key items were measuring unpaid care and, to some extent, the suitability of the home environment. So we then had to think about, if we were to collect extra information, what would we need to consider? And our key criteria is that it would be relevant to care, meaningful to the purposes of an MDS, and feasible to collect, taking into account all the principles that we previously discussed. So we undertook a scoping review to identify the existing tools for the 2 new areas proposed, the first of which was the home environment. And for this, we looked at the academic literature. We used a recent review in the area. We spoke to expert sources, and we also looked at databases. Through the following, we eventually identified 20 potential measures of home environment, and 7 potential measures for unpaid care. So we're going to first look at the home environment measures that we reviewed. So our first task was to explore all of the tools and to group them into what was a kind of meaningful thematic areas. We determined 6 categories. So home maintenance includes things like tidiness, hygiene and disrepair of the home. Access and adaptations is about the extent to which what is available in the home enables daily activities. Utilities encompasses basic first order housing needs for electricity, water, heating and temperature control. The next area is structure and fittings, which covers the dimensions of rooms and available space to meet persons' needs, as well as furnishings, fixtures, fittings. And you can imagine that these things also can have a bearing on the ease of providing care in a home situation. Hazards covers things like safety aspects and can include access to arrangements for emergency support. And finally, comfort relates to the meaning of the home and how it's perceived by the person. So what we then did was to look at what the tools we identified contained according to these thematic areas, and then we grouped them by discipline. What we see is how particular conceptualizations of the home environment are patterned across the disciplines. So, for example, the two measures derived from gerontology were solely concerned with comfort and the meaning and perception of home. In contrast, and unsurprisingly, we see that 7 out of the 8 occupational therapy derived measures cover access and adaptations and hazards. But what we also see to some extent is what's shared across the disciplines in terms of what's perceived to matter when assessing older people's home environment. Overall, measures of access and adaptations and hazards are the most prevalent, being covered in around 3/4 of the tools. We then looked at how adaptable these tools might be to home care settings. Most of the tools which we identified were considered to be unsuitable due to their length, in particular the occupational therapy tools, which are largely designed for diagnostic purposes, are particularly lengthy. The other issue is that most, although not all of the tools, are designed specifically for use by professionals or by researchers. Going back and reviewing the tools, both in their length and both in the themes that they're covered and the way they ask the questions, overall we get a picture that it wasn't possible really to find a consensus regarding what aspects of home environment might matter most in home care settings. Every tool is very much a product of the discipline that it comes from, and more specifically the purpose for which it was designed. So just because a tool was simpler and shorter didn't necessarily mean that it would be more appropriate. So the question is, what, if anything, could be included in an MDS for home care that would not unduly burden care providers and would be seen as meaningful? Overall, we concluded that there are some items where existing tools that could be relevant, but the consensus is really required on what matters most in home care settings and what information care providers feel they might be able to provide. So moving on to our review of unpaid care measures. The importance of including a measure or measures of unpaid care was discussed by all our stakeholders in the previous work that I mentioned that we did alongside the Dutch study. And that was including people drawing on home care support and their family members who had the concern that their input should not remain invisible. We know that support from unpaid carers can vary considerably, but we also know that care performed by family and friends can influence whether someone has unmet needs and can affect how much they benefit from home care services. Also, we know, of course, supporting carers is an explicit goal for social care services. So we found that there are numerous measures of unpaid care in UK longitudinal and repeated cross-sectional surveys. There are also measures in the census. All of these are used for planning, are currently used for planning policy or support, but none of them are specific to the home care population, which is where the gap occurs. In the UK, there is no routine system for taking any measure of unpaid care from the home care population. However, internationally, the INTERRI home care minimum data set tool, which Alex mentioned previously, is used and mandated in several countries, does include several short questions on unpaid care, including caregivers' well-being and the perceived sustainability of caregiving. Overall, though, there is quite a lot of variation in the measures for types of support provided by unpaid carers. For instance, INTERRI asks for an estimate for the amount of unpaid care received in the 3 days prior to assessment, and other tools have very different ways in which they try to estimate the amount of care that's being provided. So overall, we concluded that there are some simple questions that could be included potentially in an MDS for home care to capture unpaid care, and that these would most likely want to align with the types of question used in the UK census. However, the feasibility of estimating things like the volume and frequency of unpaid care is much less clear, especially given that care needs can fluctuate considerably. So finally, just to touch on our stakeholder consultation. We reached out to care providers and commissioners who had previously be involved in our work as part of the HAPRU study and held a focus group with them. We spoke to them specifically about the areas that we were focusing on as new possible domains for an MDS, and on some aspects of what a home care MDS might contain that we knew are not widely measured in home care, such as quality of life and nutritional status. So the stakeholders that we spoke to were more or less unanimous in saying that all of these areas would be considered to be important in home care settings. But obviously and unsurprisingly, they said that any measurement tools would need to not be lengthy or complex. Although it was also the case, and a number of them did mention to us that they are already using measures, for example, to look at hazards in the home environment as a matter of course. And so a big issue here is about the alignment of any future data collection with their existing systems and also wider requirements. And finally, one of the key things that they talked about was the sensitivity, particularly things like questions around unpaid care, about its potential impact on clients and staff. So finally, just to conclude, we believe that some of the content from a home care MDS could already be drawn from the existing care home MDS, which has been trialled successfully. We know that there are some gaps in terms of how we might measure the home environment in unpaid care. We hope that the work that we've done has moved towards helping to answer the questions about what we might include in that, but we know that a little bit more work would need to be done around that. Overall, an MDS, there would need to be a consensus. Piloting of measures is obviously vital, and we know from what home care providers that support for implementation would be absolutely imperative. So that's it. Thank you very much.
Thanks, Vanessa. We have our first question in the chat. So we have a few minutes for questions, which is quite a big question, really. What is the rationale for an MDS? Is it data items that providers should collect or provide, or items that would be important for research, or both?
I mean, the big challenge with a minimum data set, which is not something that I've just personally grappled with, but the whole of the team, and also obviously the DAPRU team in developing a minimum data set for care homes, is what it should contain and who it's for. And the aspiration is that it should contain data which covers many needs. So it would contain data which obviously would tick the box in terms of asking policy related questions that national government would be interested in, but also researchers, but also the things which are important to service users and family members, what's important to local commissioners, what's important to integrated care systems, etc. So it needs to cover everything and yet remain minimum, and that's where the challenge is. So I don't know whether Barbara has anything to add.
No, thank you. I think that covered that. Keith has just added a question of who would you envisage would be primarily responsible for gathering MDS data, particularly given the paucity of time available to carers. And I think that this is an issue that comes up in care home and home care MDS discussions. I think the idea is that, as we were saying, that the data burden should be minimised, and certainly with the care home MDS, the approach that we took in the HAPRU study was to look at how we could link together data that was already being collected, and we looked at what care homes were already collecting, and their data collection burden already exceeded anything that you would want in an MDS. We did a similar exercise within HAPRU to look at what was currently collected by home care organisations, and even there we find that most of the data that you would probably want in an MDS is being collected by quite a number of the organisations. So it's not really the case of adding to the data burden. It's more about curation and linkage and use of the data, so that when people travel across different settings, that actually their information travels with them. But I guess underlying your question is, are we going to ask hard-pressed home care workers to do something else within their 10 or 15 minutes or however time constrained they are? And I think loud and clear from the sector is that that's not feasible. And also, it's not about collecting the sector's data. It's about how can the social care providers be supported to use their data in a more effective way, and where it's useful to the care provision and also to the care experience, to share it with other bodies. If you want to add anything, Vanessa?
Well, it was just to add that obviously there is a real turning point at the moment with the digitalisation of social care and digital social care records. And there is the expectation as part of that, which has nothing to do with the possible development of a minimum data set, that more data should be collected at the point of care, and that daily observations and such like will be going into digital form. And so, I mean, we are aware that things like a lot of the background information on data, client characteristics, demographics and stuff, that would need to be part of an MDS, that traditionally often that's been the role of team managers that might go in and do the initial evaluation. And with a system that would be routinely collected, ideally we would like to see that happening more at the point of care. But we know, but with all the caveats around care workers' capacity to do that. So I think it's something that the developments towards digitalising social care records have a big impact upon.
Question from Rosie. Did you explore the level of engagement recipients of home care have with community resources?
Sorry, what was the question?
Do you explore the level of engagement recipients of home care have with community resources?
No. I mean, there is I think that the picture that I showed were the areas that might need to go into a potential MDS. I don't think that is completely exhaustive. And there is an area there which is what other supports, like unpaid care support, obviously is a huge area for people, and it is very much the backbone of care that's provided at home. But there are obviously other supports. And yes, I think we do believe that it would be interesting if there was a minimum data set in home care to ensure that it somehow collects data on what other inputs people are receiving, and that, you know, and community support would be an important part of that, but we haven't looked at how we might do that yet. Does that answer the question?
I don't see any other questions in the chat or in the Q&A. So I think at that point, it's just for me to say a huge thank you to Vanessa and Alex for their presentations, but particularly for our audience for attending and for your engagement with the topics. We will be running a webinar series in 2025, and we'll be advertising that on our website, which the link of which has gone in the chat. So just huge thank you for coming, and we hope you found it interesting and informative. Thank you.